we start this session by setting the stage for our expert, Dr. Shagun, who will be taking the challenges that we highlight. She'll be taking it further and she'll add her inputs. So the first case is of a 31-year-old non-consanguineously married woman, 30 weeks of gestation, primigravida, spontaneous conception. She comes with an antenatal ultrasound that shows a progressive unilateral ventricular megaly from 24 weeks of gestation.
Just before we go back to the discussion, I just wanted to highlight some important points when we are dealing with ventricular abnormalities. To look for the lactic ventricles, we assess them at the level of the thalamus. Once you identify the thalamus, you measure the ventricles. It usually should be less than 10 millimeters. It can be variable up to 14, but from the age of 14 weeks of gestation for a normal ventricle, it remains relatively stable. So that is one helpful pointer, that if you identify any abnormalities in the ventricles after 14 weeks, one must keep a track of that. Or the third ventricle, again assessed on the most commonly on the coronal sequences, and it should be less than 4 millimeters. The fourth ventricle on the SAT sequences, you have the anterior posterior dimensions, should be less than 7 millimeters. Some pointers to notice: there can be discrepancy in the terms of measurements around up to 2 millimeters from the ultrasound MRI. And separation of the choroid plexus to the medial wall of the lateral ventricles can be up to 3 millimeters, and there can be normal asymmetry of the lateral ventricles up to 2.5 millimeters if it is not dilated.
So we'll go through certain the common CNS abnormalities, and we'll try to see mainly because I'm a geneticist, so from my point of view, like where does genetics come in, or what tests are advised for what scenarios, and how do they really complete the picture? Because the issue we all know when we are dealing with the prenatal scenarios is that very often we don't have the complete picture at one point of time, and of course the picture keeps changing also throughout pregnancy, and still it never becomes complete because there are certain things which, whatever imaging modality we use, we just cannot see certain things in the prenatal scenario. So there are a lot of complexities, and of course we know the complexity arising because of the legal limits of termination. And as Dr. Jyotsna was very well mentioning, the scenario especially relevant for our country, where then I think there's a question on CMV positive in baby. Do we have to give antiviral to the mother also? I think baby, of course, we would need to give, but to the mother, I don't think we need to give unless and until she's immunocompromised or has, most of the in an immune competent individual adult, we don't expect CMV to have significant this thing. But in case she is immunocompromised or has some symptomatology, CMV associated, then probably we could give. But I don't know. I mean, I'm not an expert on CMV as such. So as far as the mother is concerned, maybe if you could add something.